This is Chapter 21, Rehabilitation of Knee Injuries. When we talk about the knee, there are many anatomical considerations to note. Lots of bony landmarks, soft tissue structures, and articulating surfaces. Hopefully these are solid in your heads, because I'm guessing you use these and see these a lot in clinical practice. I'll not spend time discussing this, but it should be known by all of you. If you're a little shaky with the anatomy, I highly recommend doing a review prior to the first class session of this lesson. As I've stated before, this slide and the next are the foundations of rehab. You need to know how to address these goals specific to the body part in question, as indicated on this slide. Then you know when to address them, as indicated on this slide. One thing to note on this slide that will be somewhat unique to the knee is the prehab or pre-surgical exercise phase. Most body areas do not really have this consideration, but the knee does in most cases. It has been within the last 10-15 years or so that this has been widely accepted protocol prior to having ACL surgery. It used to be that you had surgery soon after the injury, as with many other surgeries. However, it has been found that someone who is stronger going into an ACL reconstruction surgery is stronger coming out and has better outcomes long term. One question to note is, about how long does this pre-surgical exercise phase last? A better question may be, how long do doctors tend to wait between trauma and surgery in an ACL grade 3 sprain? As we have done with lessons before, we will break down the different phases and talk about what is done in each with consideration to the knee and potential injuries you will see. Those injuries are on the next slide. While rehabilitation of the knee is like other body parts in that you use your evaluation to guide what you do, there are many types of injuries that you will see. Knowing some of the nuances of these injuries can help inform your rehab programming. We will go over some of these for the injuries listed. The MCL of the knee is stressed by valgus forces. These are relatively common in contact and collision sports. Treatment of any grade of MCL sprain is conservative. Rarely are these surgically repaired, even in conjunction with a grade 3 ACL sprain and subsequent reconstruction. Even grade 1 MCL sprains can require a period of partial weight bearing or non-weight bearing. This will be dependent on the patient's function. Whenever the patient can ambulate normally and pain-free, you can allow full weight bearing. From there, follow the evaluation to go through progressions in the various phases. The LCL is stressed by varus forces. An isolated LCL sprain is the rarest of the knee ligament injuries. Significant LCL sprains, such as grade 2 or grade 3, are likely associated with other injuries to knee structures. Like the MCL, the LCL is rarely surgically repaired. Also, like the MCL, you may have a period of partial or non-weight bearing in the acute stages of this injury. The progressions will be very similar to the MCL. ACL, grade 3 sprain, is an injury every athletic trainer knows about, and many athletes and athletic trainers have experienced firsthand. It is like any other injury where the evaluation should guide your programming. Because it is so common, there are many protocols and programs that are meant to standardize the process and give patients a long-term prognosis on the length of time needed to return to participation. Some of these templates with their respective orthopedic surgeons are listed on page 675 and 676. If you are in a clinic in central Indiana owned by Dr. Shelburne, that will probably be the protocol you follow. However, all of these should be done with keeping the evaluation of the patient in mind. Some recoveries will simply take longer than others for any number of reasons. So even with one of these templates, do not forget about the evaluation component. Before I discuss the last component of ACL injuries I feel is important to know, I want to give you some quick background information. The book mentions multiple times a conference, the Hunt Valley Conference. This was an international conference in 1999 with the goal of coming to a consensus about best practices to prevent ACL injuries. I have the NATA position statement on prevention of ACL injuries linked to the page. It is from 2018. So keeping that in mind, the other thing I will mention regarding ACL injuries are the risk factors. Page 666 in the book divides these risk factors into 4 groups: external, internal, hormonal, and biomechanical. Both the text and the position statement state there is no true evidence yet that internal factors like intercondylar notch size, ACL size, and lower extremity alignment significantly influence ACL injury. The text states there is no true evidence yet that external factors like shoes, playing surface, practice versus competition, and weather significantly influence ACL injury. Females in the pre-ovulatory phase of their menstrual cycle may be predisposed to non-contact ACL injury, according to a systematic review by Hewitt in 2000. The position statement does not really discuss external or hormonal influences. Both the text and the position statement are in agreement that biomechanical factors are a modifiable risk factor. The text notes that neuromuscular factors could be the biggest reason for the greater incidence in females compared to males, and the position statement mentions how improving neuromuscular control with a multi-component preventative training program can decrease female ACL risk up to 75% in female soccer and basketball players. Keep this in mind when working on any rehabilitation program for these populations. PCL sprains are listed next. PCL is the strongest ligament in the knee, and these are many times injured along with another ligament on meniscus. Even though it is an intracapsular ligament, it is not surgically repaired often. Most treatment is conservative for any grade of PCL sprain. Because PCL primarily prevents posterior tibial translation, biomechanics can be altered negatively. This can result in greater joint reaction forces on the patellofemoral joint. Think about the anatomy as to why that would happen. Controlling the posterior shear will be key for a patient with a PCL deficient knee. Meniscus injury is the last bullet on the left. Even though the book says that a positive Murray's test can indicate a meniscus injury, trust the eval book and use Thessaly test as a more definitive test for meniscal pathology. In athletics, these will almost always have some sort of surgical intervention. The surgery performed will have a significant impact on how you proceed with rehab. The partial meniscectomy may not require immobilization or non-weight bearing. The patient can be partial weight bearing soon after surgery, progressing into full weight bearing. There are plenty of stories in the AT world about NFL players having a meniscectomy on a Monday and playing the next Sunday. The former basketball coach I worked with always reminded me of a patient that only took 8 days to recover from and return to full participation after a partial meniscectomy. He thought that should be the norm. That is not very realistic. As the book says, you expect about 2 weeks to recover back to full participation after a surgery. For a meniscal repair or transplant, you will have time in non-weight bearing and immobilization. The book says 2 weeks, but I have known it to be a little longer than that. Different surgeons have different protocols. After that non-weight bearing time, you will progress very, very slowly. Page 680 in the book has a pretty good template to show what the progression looks like. For the conditions on the right, most are due to microtrauma. Common denominator in most of these is improper mechanics putting stress where it typically is not. Think about some of the patients you have seen with chronic knee pain. Where is the root of their problem? Probably in this order: hips, then ankles or feet. This is where a thorough evaluation comes into play. You need to be able to sniff out problems away from the site of the injury. This is where the SFMA can be valuable. It is meant to give you an idea of how the body moves together using select motion, making your evaluation a little more efficient. But your evaluation skills, when used purposefully, can find these discrepancies also. If you are not familiar with the conditions in the right-hand column, be sure to consult your text and/or your eval notes to get a background. These will be discussed at some point in our lesson.